you're ready, I'm just going to.
Can you all see that? Oh, not yet. Hold on. How about now? Okay. So whatever I'm doing, I can't see the chat. So Elizabeth, if you see a question in the chat, would you just interrupt me and tell me? So you guys can see this, okay?
Yes, we can see it perfectly.
Well, in the evidence of full disclosure, I'm coming to you not as an addiction psychiatrist or an addiction medicine specialist, but someone who began my career actually with substance use with adolescents and largely has been either on the detox end or on the outpatient end. So my intent today is to really kind of review the options for you regarding kind of more outpatient care once someone's been successfully detoxed, often has a period of sobriety, or being met in a different place than an acute need for residential treatment or inpatient treatment, and really linked to sort of the outpatient management medications to help someone promote their recovery in care. And some of this is, as I did this, was reminding myself how much we need to grow and how limited options sometimes that they have. But there are substantial options that I think get underutilized alongside other things. And although I won't dive into this, I think this is a very med-focused talk, but I again, 100% will say that the success of substance use treatment really involves substantial amount of psychotherapy, motivational interviewing, treatment modalities alongside medicines. But one of the things that I was reminded of in doing this is how hard an abstinence-only approach is, and how critical that most people have success when we meet kind of their psychologic alongside their biologic needs in these chronic illnesses. So this is a review today of the FDA-approved medications for substance use treatment. And then I wanted to, at the end, sort of talk about that there's, especially in stimulant use disorders, a lot of need for more understanding and approval. So I was going to just briefly touch on some evidence base that exists without FDA approvals if we have time. But as always, please interrupt me. Love questions. I know there's actually a lot of experience on this call with providers that do this every day. So I also welcome your shared comments as well from your lived practical experiences is just as important. So we're going to talk about these three classes. Unfortunately, what you'll notice is these are the only three classes of substance use disorders that have FDA-approved medications, which should tell you right away how limited the base goes beyond these three. But these are the three categories that have an FDA-approved medication. We're going to talk about some off-label options if we have time, but this is in no way, shape, or form a great start. We need a lot more FDA-approved treatments for lots of other substances, and certainly at the forefront of massive research needs too. So we're going to start with opiate use disorder, and it's probably opiate use disorder in our state that really got this idea started that we need to move away from abstinent-only approaches to understand truly that these are medical disorders. These are complex biological etiologies that really do create cycles of cravings. And so when you talk about medications for substance use disorders, we're talking about a variety of targets. So, and as we look at these, you'll see the target. So the targets are medicines that make me not feel bad every day because I'm not in chronic withdrawal and continuing substance use seeking behavior to not feel bad. So some medicines fulfill that category. Some medicines are targeting specifically craving pathways to try to reduce the biological urge of cravings to direct use. And some of them are sort of designed to be adversive, that if you use it, it doesn't work, or you use it to prevent yourself from using so you don't feel high, or in the case of one for alcohol, you actually, if you used while taking this one, you get sick. So I call those the adversive kind of medicines. But when we look at opiates, we have many different possibilities that that are part of this. And I think with like patients, to me, this is the discussion point of what really meets their needs and really knowing what they're comfortable with. So it's talking about, and honestly, this is sometimes something that the therapists are much better at starting than me really talking about the choices so that they know what medicine will fit best into this person's life. And really good substance use and addiction counselors talk about this with their patients and inform us about what their patients most interested in, because you have to have buy-in. They have to take it, they have to be willing, they have to be able to make the appointment or the frequency of how they have to take it. And so this is a huge opportunity as a if you are a prescriber to make sure you're talking with the treatment team so that everyone is supportive of this choice. So the first one is I want to just talk about, because I think those in the substance use world do a really good job of this, but I really sincerely think if you live in West Virginia, if you're a pediatrician, PCP, and you aren't even doing substance use, you need to understand Narcan. There are so many needs for this, and you'll often see this on the side of the road where they're giving it out free. First responders are calling it, but this is an emergency rescue medication. It's naloxone. It reverses overdose, and that is what leads to death in opiate use disorders. You will not die from withdrawing from opiates about 99% of the time. It's not a lethal withdrawal. It's lethal if you overdose and take too much. And if you've been detoxed, if you're around people still using, you may also save a life by administering it. Some people will administer it to themselves as I start to feel it. So everyone should have access to Narcan. I do not know the details. I think I'm a pharmacist. Alicia on the call may be able to give you the instructions, but I don't even think you need a prescription. I believe this is a medicine that you can go to a pharmacist, and the pharmacy has ability to even just give you through the public health order directly from the pharmacy. So I would make sure every patient that has an opiate use disorder, every family member that has a loved one with an opiate use disorder, even if it's for chronic pain and not, should have an access to this prescription alongside whatever else you're doing. So never forget Narcan as we talk about this. It is readily available. I think it's free. You just need to walk in and ask for it. They will fill your prescription. I don't even think it requires any authorizations. We should be writing it a lot more
Dr.
than I think
Swagger,
we do. Yes.
sorry there. Yeah, we had someone chat in saying they're giving free Narcan to any WVU student who wants it before they leave for spring break, which I think is a great idea. Yeah. And is it hard to administer, or is there any training for this? Like, what if you want to carry it and you see somebody, because I have seen people and I'm like, what do I do in this situation?
Like I actually had my box in this room, and I don't know where I put it, but it's pretty simple to use. There's a quick video you can watch. It's a nasal sort of squirt, and you can like carry it in your backpack. And one of the things I will tell you, this is just a aside outside of substance use. One of the challenges of substance use treatment is we sometimes focus so much on the individual that you'll often hear stories in other walks in mental health of someone who watched someone die or lost a loved one because of an overdose or walking in on someone. That is complex and difficult in its own right. It's very powerful when you don't have control of situation to give someone something they would have control over. So walking around with Narcan is a psychological comfort, even if you don't, as to family and loved ones, to have. But it's quick and easy. You can actually YouTube yourself a video. I should have done that. We can do that just so that you know how to use it, but anyone can use it. It doesn't require an injection or anything like that. And
Everything's
so
on YouTube, so I think we'll be okay.
everything's on YouTube. But yeah, maybe Alicia can give you exact instructions. It's a nasal spray. I don't remember the squirts I'm in, but it's real simple.
It is. So it depends on the product. Right now we have several different products because some are higher strength than others. So they're starting to see, higher withdrawal, in some of the 8 milligrams or whatnot. But of course, when you're saving a life, you're not too worried about that. But I did just want to back up a little bit. So the standing order that you had mentioned, that would be if you're wanting to bill it through your pharmacy. or your pharmacy coverage. So if you wanted to be paid for by your insurance, you can just walk into the pharmacy and they can bill it under the standing order. We should have, and I don't know how available it is quite yet, just the ability to go in and buy over the counter. So not even behind the pharmacy, that is coming up. And then for anyone who's interested, if you're not familiar with the program, I always have our students do it, and I've done it. There's Naloxone Heroes, and it's on Help for West Virginia. And it is like a short, maybe 45-minute course that it will train you on how to administer it. And then they actually ship you 2 doses of naloxone. And so you can be a carrier, so you have it as well. But yeah, it depends on the product. They've removed the one that's the injection, I think, for cost reasons. I don't think that, but most are up the nose now.
There's also one other thing. I don't know if Alicia or Dr. Swagger, somebody mentioned that they keep it in their glove compartment, but they're a little worried about the temperature changes that might impact it. I didn't know if you guys had it.
Again, it does have some clear warnings about temperature and getting too high. I believe I do not remember the limit. Alicia, I'm going to tap you again if you know the
So
answer.
everything, of course, is within this nice little bubble. But if you want, as a resource, I've been working with the Drug Intervention Institute, and they sent out some literature where they actually tested it under different conditions. And so while it's not FDA approved, it is supporting literature. So Elizabeth, I can share that with you if you want to send it to the group. I'll dig that up during our call.
Yeah, thank you very much. Absolutely. Yeah, you have till tomorrow, so even if you can't get it right away.
Perfect. Thanks.
Yeah, so never forget naloxone. The other one that's kind of in this category is naltrexone, which sounds a lot similar to naloxone, but it is a opiate sort of antagonist, but it has sort of a very different purpose. Now, if you give naltrexone to someone using opiates, you will precipitate withdrawal. And so that is very much kind of how naloxone works as well. But the purpose of naltrexone is quite different. In fact, naltrexone is sometimes packaged with you'll see when we talk about Suboxone, you'll see it kind of packaged alongside the buprenorphine in the packaging, and it's designed to kind of reverse the opiate effects if you crush it. So it was a diversion attempt, but naltrexone as itself is an FDA approved medication, and think about this medication for your patients as kind of reducing cravings, because it certainly reduces the cravings if you can't activate the receptor. And if you give a long-acting form of it, it can sort of, if someone would take an opiate medication, it wouldn't work. You wouldn't get the high. You wouldn't get the euphoria. So in that effect, it sort of prevents it, but it also kind of helps establish some of the cravings that would come from the use. And it comes in a long-acting injectable form as well. And we'll talk about that one a little bit more as well. And then on the right-hand side of the screen, you have your opiates that really kind of fall in that traditional medication-assisted treatment, where the idea here is we're replacing kind of the substance of abuse with a longer-acting, safer alternative designed to provide a steady daily effect on that receptor to reduce sort of the complicated behaviors that come from having a substance use disorder. And I'm gonna talk more about that, because this becomes a very hard thing for some people to kind of wrap their heads around until you buy into the culture of medication assisted treatment. Well, I'm just giving one drug to replace another, and that is not the purpose at all. And that is something that often requires a lot of psychoeducation, because people just think they're getting hooked on a prescription in place of using something, and that is not at all the intent. That is not at all the purpose. So we really want to go through kind of that as well. Oh, I'm sorry. That's my little so the goal of thinking about maintenance, so MAT is medication assisted treatment. It's been replaced with a more appropriate term for opiate use disorder, which is MOUD or however people say, but it's MOUD, and it's medications for opiate use disorders. So we're getting kind of more specific and more appropriate in our language. But The goal of thinking about this is, one, we know that abstinence only programs afford about a 5% success rate to people and do not have great outcomes by themselves. And so we want people to really maintain control of this illness in a way that lives their lives functionally safe without risk of overdose and breaking that withdrawal cycle. And so a lot of the challenges regarding this is that people use to, again, not feel bad because they're in withdrawal. So you want to prevent that continuous cycle of withdrawal and feeling bad. But you also want to reduce the drug seeking behaviors, because what gets people into big trouble and into the justice system is if you constantly feel bad and you're searching for substances. This is how people can get, may go looking for substances, may steal, may get involved legally because they stole money or sold it, and then and started dealing to support a habit. And so a lot of the functional problems from substance use are those behaviors. And so we want to make an effort to reduce that. We want to keep people in treatment. You cannot provide successful counseling or therapy to someone if they're in active withdrawal. They feel awful. They're not going to be able, you cannot give someone a new coping skill if they're actively in that much distress. So it's really designed to engage people, stabilize the physiologic part going on, and get out of the binge and purge. And we've talked about that before. When you're binging and purging your system of higher levels and lower levels, you're in that withdrawal overdose, high cycle that causes enormous physiological distress as well as emotional distress. And so we need to get all those things kind of aligned. And so these three medicines kind of do that. They're all opiates themselves, but they have very different properties. They have very different patterns. So buprenorphine is actually a partial opiate antagonist. So if you think about the opiate receptor, it's kind of partially sitting on there. That means when you think about the response pattern of it in your system, it will increase to a certain point, but you can't really overdose on it, because once you get to such a dose, it blocks the receptor and kind of stops working. So you can't overdose and keep getting high from it or getting the physical response that you might want from it. And so it's kind of a natural choice. It can be taken daily. It can be injected subacute. We'll talk about that. But it's one of the challenges with opiates is death, and the death comes from the respiratory suppression from the overdose. So if you're designing a medication to kind of level out, but you don't want someone to take too much to keep getting that high effect or taking more, this mechanism of action of buprenorphine really fits that bill. When combined with naltrexone, that blocker, that is where we have Suboxone. Buprenorphine's been used as a pain medication for a long time. They gave it to me when I was pregnant. But when it's combined with in a film, it helps, it can't be crushed or injected. And so because the naltrexone, if crushed or broken from that film, would make the substance inert. So that was part of that fancy packaging we've talked about with other medications at times. So this can be something that can end up being taken daily at a lowest, safest dose that prevents cravings, but also prevents withdrawal. So we can kind of get people into and break that cycle. Methadone and methadone is challenging systematically as well, because you have to have a special license as a facility to write methadone for substance use in the state. They're trying to get a moratorium to increase that, but methadone is kind of challenging to access because our state has not been allowing new methadone clinics or providers for a while. I believe there was just some law to lift that, but I'm not sure. We've seen a lot of problems, but people would have to travel to a treatment site and take it and receive it daily or every couple of days. They would need to take it. It's a very long acting opiate. You can actually take too much of it, but it had such a long half-life that it had that same concept of reducing the ups, downs of the short-acting opiates. And it fully hits that receptor. So too much methadone, you can absolutely die. So it was controlled in that way to get the lowest possible dose, and giving it, not giving, so you can't take a bottle of methadone for substance use treatment home. You have to go and get your dose or a set amount of doses from a specifically licensed facility. So I think a vast majority of folks on here that are writing prescriptions are probably definitely aware of this. This is a huge win for substance use treatment. There's always been sort of this idea that you could not write methadone or buprenorphine. You could write it for pain, but you couldn't write it for substance use disorder unless you had specialized treatment. And then they created this X waiver, and they were trying to encourage everyone to get an X waiver. But they had limits on how many people you could serve. And what ended up happening was, I think instead of opening up the gates for more substance use treatment, it kind of funneled it unintentionally. And so last year, there was this federal removal of the waiver to really say, if you hold a DEA registration that gives you Schedule 3 authority, you may now prescribe buprenorphine. You still can't prescribe methadone. You got to have that facility waiver, a different path, but now you can. So anyone who has that DEA permission can and should. And I know there are many nodding heads on here, well beyond me, but it has been actually more helpful, not, and probably more lives saved by encouraging primary care providers, ED providers, and all physicians and nurse practitioners that have prescribing authority to do this than to just limit it to mental health professionals. So I know I'm talking to the audience, but to succeed in making this world a better place and making substance use treatment more available, it has to be all providers in this fight. And so this is a huge win. I know there's some folks on the call that are involved with COAT and other. I don't know. I have personally seen a lot of people still wanting to do this or magically start prescribing it yet. But I hope we'll get there. And the removal of the waiver was a barrier to that. I don't think they realized that when it started, but that was part of the push. So if you've seen this improve things already, let me know. I'm not sure I've seen that yet, but it really was a critical step to remove it, to try to get this just an option even in primary care and emergency rooms. I feel. Whoop, sorry. Okay. So those are the opiate use disorders one. I think I heard maybe 2 people that were involved in COAT clinics. That was initially I think, was it chronic or some comprehensive opiate addiction treatment, I think was the acronym. And so a lot of those clinics model well established in West Virginia to really provide and have daily check-ins regarding the need to continue Suboxone were a huge win for them. And so I know they're all doing that, but this is really something that can be done in any outpatient office alongside connection to therapy as well, and want to move in that direction. Alcohol use disorders is where we're going next. That's the next realm of FDA approved treatments. And I want to say that I think with some of the focus on opiates and now meth, I think we've lost the discussion about how problematic alcohol use disorders still really, really are. And alcohol use disorders can be addressed at various points. Now, alcohol use disorder, remember our biology, is a substance you can die from if you have complicated withdrawal. So as a provider, you have to start with this question, do they truly need detox? Because you can die. Alcohol use disorders, I think, almost has a 10% rate if you've had delirium tremens or complex autonomic instability from long-term alcohol use, you really can die in the withdrawal. So there has to be a discussion with someone regarding if they truly need inpatient. And certainly in our current care system, you can receive inpatient detoxification for alcohol if you have high risk of complicated withdrawal, history of seizures, vital sign instability, delirium tremens, and an ASAM 4.0 level of care. And then the ASAM 3.7 level of care, which we could do a whole another echo on if people wanted to learn about those levels, could also be a safe place to detox someone from alcohol that does not have a history of complicated withdrawal, but just needs a taper. And so that may be the first step before prescribing these, because most of them do require some period of abstinence and could be and are often started alongside care. I do a lot of reviews on 3.7s, and some places are really, really good at offering these things before they leave from their alcohol detox. But unfortunately, more often than not, they do a straight detox and offer no maintenance medicines for alcohol. I would love to see these utilized more. I don't know if other people have different experiences with them, but I think they are highly underutilized. So there are 3 that are FDA approved for alcohol. You will see again naltrexone, and yes, it is the same naltrexone that we were talking about with opiates. And we'll talk about that here in a minute. How does that help alcohol? And then we have 2 other kind of more uniquely acting agents that are FDA approved for alcohol use. So naltrexone blocks the effects of opiates, right? So how is that helping alcohol? Well, opiates pathways in my short bio lesson actually have a role in all substances of abuse. It can be a reinforcing piece. And so actually blocking that pathway actually does help in several other substances of use. But it is well established that this medicine can help cravings for alcohol as well. And so it has 2 formulations and is FDA approved for both. There's the daily oral dose of medication that typically starts at 25 milligrams, and then a typical daily dose of the orals between 50 and 100. And people need to have discontinued several days of drinking before they take it. Is part of the guidelines. And so they would take a daily oral pill to help just prevent the cravings for alcohol. Now, of course, because this is naltrexone, you have to also very much screen that they haven't taken an opiate. They aren't having current opiate use medicines for pain or whatever they may be on, because if you give this for alcohol use disorder, you will precipitate opiate withdrawal. And so people do need kind of to be aware that if they would have an acute pain need for a surgery, if they're given an opiate at some point, that it would not work. And they may need to taper off of it, but it definitely can be given. And there's actually a long-acting injectable form now that can be given of naltrexone. It's a monthly injection. It's in the buttocks and given as a deep IM injection. And it is also maybe a very, very helpful option if you have dual alcohol use disorder and opiate use disorder for your patients. Again, you have to be opioid free they recommend 7 to 10 days before giving this, or it will cause precipitated withdrawal. The other 2 medications are pretty unique to alcohol. We don't totally know how acamprosate works. People sort of believe it involves kind of modulation of the glutaminergic and GABAergic systems. And when you think about the biochemistry of alcohol, you're traditionally activating GABAergic receptors, or thinking about how it's a lot of the alcohol withdrawal complexities and cravings are often felt to be kind of a mismatch between the excitatory brain neurons and the inhibitory brain neurons, and glutamate's excitatory, GABA is inhibitory. And that dysregulation of the excitatory and inhibitory neurons creates a lot of the physical discomfort feelings regarding alcohol cravings and use. So this is a medicine designed for people that are in recovery who want to avoid kind of drinking or specifically craving. It doesn't really cause withdrawal symptoms. It doesn't prevent withdrawal symptoms. So it's not really targeting cravings or withdrawal, but it kind of helps. I think I've heard it kind of mostly help in anyone that is with some of the physiological anxiety like type things that go around what often drives some of the reason to use. It typically starts on the 5th day of abstinence, and so it's a perfect sort of, if you see someone immediately coming from an inpatient facility or detox facility to an outpatient appointment, they still have maintained their sobriety, wasn't started at the end of the detox. It's a great option to consider starting to just, again, add some additional support for that physiological arousal, cravings, stuff. Now, it is not a particularly easy medication to take, and I think this is why it's underused. It requires you to take 2 pills 3 times a day, which is really, really hard. So that's 6 pills 3 times a day. The schedule really is really challenging to a lot of people. I will tell you, I've had some people do a very good job with this, but it's very, very hard for people to remember. I'm not even sure I could remember pills 3 times a day, in all honesty. And so that is a real challenge for a lot of people. I've had some people tell me they take it twice a day and that it works. But it is a hard medicine to dose and be compliant with. If you have some, I mean, oftentimes if people say it really helps, it's really focused on how to remember and accomplish this dosing schedule. And certainly any ideas about that are welcome. But I think that is honestly one of the biggest barriers to its use. Any questions about that one? I'm sorry, I can't see the chat if there are any there.
No, you're doing great.
Okay.
That's good questions there.
Okay. The next one is sort of an old school kind of biochemistry medication. And this is really the aversion therapy kind of approach with a pharmaceutical. So disulfiram actually blocks alcohol dehydrogenase, which is the enzyme that breaks down alcohol. I think I learned about it in biochemistry and remembered it as a target for this medicine. But what it does is when you drink alcohol, normally this enzyme breaks it down into less toxic metabolites so you can excrete it. When the enzyme that metabolizes it is blocked, what gets stuck in the pathway of its metabolism is a substance similar to formaldehyde, which is a toxin. And so the idea with this one is you take it every morning, kind of so you plan not to drink. So if you would drink while taking this, you would get sort of violently sick. And so it requires a very high level of motivation for people to get up and take it. And for some people, again, this is where you have to get the buy-in and know what works best for somebody. But for some people, that helps because it's something they do and they feel it keeps them safe from the temptation. That being said, that is really scary to a lot of people. The violently ill part, I think, is what we're supposed to say. I mean, I've had people tell me, "Oh, I drank on it; it didn't do anything." I've had people freak out about, what if I take mouthwash and wash my mouth out with an alcohol base? I'm going to be violently sick. And so I will say I've only had one person tell me they truly felt violently sick when drinking on it. I think a lot of people are more fearful of that than are their experience, which I think is sort of the point. But people that commit to this do it with the understanding that it helps them prevent it. And so you have to have their buy-in. This is certainly not something you force upon someone. It requires their kind of compliance, but it can be a really helpful thing. It can be really helpful. I will say, and again, any ideas you all would share, but this is actually one strange. None of these so far, and I should say this, none of these are FDA approved for children, except for Suboxone, that actually has an FDA approval of 16 and up. But strangely, I have I have used disulfiram with children, teenagers, because they often want kind of a reason not to drink in a pressured social situation. And and for some people, like, especially if they tended to drink at events or social gatherings, or they needed that extra little motivation to prevent themselves from doing that. This was the population I found most likely to like this. So and they you would kind of say, oh yeah, I'm on a medicine right now that I can't drink with or I'll get sick. They don't say it's disulfiram, it can be an antibiotic or whatever, but that it just gives them sort of a reason not to indulge in the environment. Is where I've seen this medicine be kind of helpful to people, and there's control with it, right? There's control because you can choose to take it or not take it, and so it is one that people that don't have that absolute daily need to use, but it feels more situational, can kind of make part of their treatment plan. I know this is a high risk situation. I can plan and have some control over taking this to maybe prevent a use that I can foresee. So it can really, it can be taken every day, but it really can be used that way, and can be really helpful. It also would cause effects, so you should not really use this one within 12 hours of drinking. This is usually one that you can start 1 or 2 days into a detox after that alcohol is fully cleared, and kind of get people. I think it also helps people in transition. I've seen some folks when people just leave the hospital, just, I'm not sure they want to take it every day, but they want to try to get through that first transition, and may agree to sort of take it for a couple of weeks, so they feel more in control, and other things are helping them. So it does require usually just make sure your liver is functioning okay. And so, usually we're checking LFTs or an EKG if there's some other chronic health risks that are typically checked anyway if they've needed it. So that is that one. And this is a really nice online guide I just wanted to share, from the Federal Mental Health and Substance Use Commission that I think is a nice guide. It talks about dosing, how to start it, what to do if you would like. I've talked to many of you know I'm a total nicotine use disorder warrior, and I don't want to. I've done a whole lecture on that before that you can probably still find on the Echo history. I don't want to spend a lot of time on this, but I think it's really important that we don't forget about treating tobacco use, nicotine, and vape. Often they are activating the same pathways of cravings and withdrawal patterns that our other substances of use are. And most of the evidence suggests that treating the nicotine use disorder alongside the other substances actually really makes a difference on just general relapse and ability to stay in recovery. And so I do not want you to forget these. I'm not going to spend a ton of time on that, but the nicotine replacement therapies are patches, gums, and lozenges. It's really important you know how much the patient is using. The number one reason these fail is we don't give them enough milligrams of coverage for their need. So remember, you want to try to match their daily amount of milligram use with how much they're doing. If they're using more than 2 packs of cigarettes, you're going to need 2 patches, perhaps longer. The gum and lozenges come in 2 and 4 hour increments. They can be used 1 piece every couple hours and tapered. Again, if people are using more than a pack a day or smoking within 30 minutes of waking up, we should be recommending the higher strength ad lib gummer lozenge. Varenicline or Chantix is a pill form that can be used. Really good results for this, and often very convenient for people that are already taking medications. This is the dosing regimen for it. And then bupropion. Bupropion is FDA approved for tobacco use disorder, but I will say it's one I didn't put in our off-label discussion talk, but bupropion is a norepinephrine reuptake inhibitor. It modulates dopamine and norepinephrine, and that pathway has also been implicated in a lot of craving pathways and use pathways. And it's an antidepressant, which is often very comorbid. So bupropion is often really considered a lot in just general SUD work, especially with comorbid depression, because it may help generalize craving pathways and reward pathways that are part of the illness. And the trick with the bupropion is you have to dose it right. You have to get up to 300 milligrams a day to really get the beneficial effects of reducing cravings and the reward pathway mechanisms. So this is the dosing for nicotine use disorder. This is sort of the dosing if you're using it for substance use disorders. This is an aggressive dosing taper, though, if you have an anxiety disorder and depression. So we go much slower with depression dosing to not activate people. But if you're using it for SUD use, you want to get to that in day 4, day 7, 500 milligrams twice a day, morning, and usually 4 o'clock, 5 o'clock. You don't want to wait till bedtime to get the benefits of this. But it's only FDA approved for nicotine use disorder, but it certainly has some off-label data for other substances. So that's it. That's unfortunately the very short list of FDA approved ones. I can get nerdy and we could talk about these things, but you will see other things being used. There are some other medicines with some evidence-based, but they don't carry the FDA approval. Topamax has been helpful from binge drinking and some impulse control mechanisms. It kind of has a effect on the inhibitory pathways, has been sort of implicated for some alcohol use disorder. Gabapentin activates those GABA pathways, again, kind of helps with some of that dysregulation in the inhibitory process. Baclofen also has some case reports and literature about its use, so you'll see people sometimes trying those if other things have failed. Stimulant use disorder, again, huge problem right now. Methamphetamine is really just a serious issue, and there are no FDA approved medications for that. We often see that causing very serious psychopathology, psychosis, aggression. And how do you help someone from that? There's actually quite a lot of targets. I throw this slide up to you. This is sort of the investigational sort of considerations and of meth and cocaine. Again, they're all sort of targeting this norepinephrine dopamine regulation and the idea of like, let's replace the activating receptor effect that's driving that. But I think a lot of interest right now is being looked at on how we can think about these medicines in the future and research them, because stimulant use disorder needs an MAT to really help people. We're really seeing people struggle with that. So I just wanted to throw out this crazy slide to hope inspire some research projects. But that is it.
Wonderful. Thank you so very much, Dr. Swagger. You did a great job as always. Does anybody have...
Dr. Hembry, put in the chat. So Contrave, that's actually a weight loss drug, right? Craving cycle use. The Contrave is a combination of bupropion, which is Wellbutrin, and naltrexone. So again, helping that craving. So yeah, absolutely. Good call, Dr. Hembry.
Very informative. Thank you very much. And thank you for that comment. Does anybody else have any questions, experience, or comments they want to bring to the discussion?
Hi, Lauren. This is Tony Tikiakio. Every day in the lay press, I feel like I'm getting articles that pop up about the GLP-1s like Ozempic and the future potential for addiction ranging from multiple substances of abuse. I wanted to know your input on that and what mechanism, if indeed that would work.
Well, I don't know. I'm just gonna give you an honest answer because the way it works is sort of through like, I mean, I can actually see it be like more helpful in many other things. I really struggle to understand how, and I'm a big fan actually of metformin and sort of treating metabolic sort of effects because of their impact on other psychiatric conditions like depression, anxiety, and sort of I struggle with understanding the biology of how those are going to help. I mean, I think, I mean, I do think there's some evidence that they regulate sort of lupin and some of the cravings that go along with, and there's that overlap in the opioid pathways and dopamine. But I just am not sure I've seen like a I mean, I've seen people throw out anything that helps in that cycle regulation, as you see from that list. But I just from a straight biology perspective, I struggle to see how that specific medicine, knowing its mechanism of action, unless it does something I don't know it does biologically on some of these pathways, I don't know that I have an answer for that. And if you've seen a paper that has actually gone down to the mechanism of action explanation, please let me know because I can't explain that. I really can't.
I would love, can I speak on a personal like note? So I wouldn't consider myself like an alcoholic in the past, no offense. But I love alcohol. And I started Ozempic and for PCOS for weight loss. And I did notice like in the past or even now I need to find a new doctor. Long story short, I don't have it right now. But I would want to drink. I'd want to drink daily. I have cravings. I need it. I want it. And then when I was on Ozempic, it's really weird. I didn't want it anymore. I didn't crave it. I could barely even tolerate 2 or 3 beers. It's like I don't know if it's because I was
Well,
so full.
well, and alcohol makes a little bit more sense, right? Because it's a sugar. And you can
Okay.
think about that in the dietary pathway of reducing cravings for like carbohydrates and sugar. Like if you think about the way, so alcohol, like have a little bit more explanation for
Interesting.
because alcohol has a sugar-based sort of molecular structure that mimics the food pathway with insulin. I struggle with that with other substances though. And Tony, maybe are you seeing it for like everything or was it more focused on the alcohol? Because that part I think I can explain better.
No, literally, I've seen articles, and again, this is in the lay press, and this could be, for all I know, pharmaceutical spend, but anything from cocaine to opioids to, I mean, across the board. And I, like you, couldn't figure out like why that would work on some of these things. But if I see anything that seems scientifically explaining it, I'll pass it along.
Yeah, thank you. That's really interesting. Wanda, I think you unmuted. Go ahead.
Just saying that it's totally opposite because I am taking Contrary for weight loss, and I like to have a drink at a tailgate once in a while, and yeah, you have zero effect. It's not fun. Which some of my friends say,
naltrexone in there just ruins your whole day when you're
right? And some of my friends say, "Can I have some?" No, no, you cannot.
I will add in like anecdotally, also being a Wegovy user, in that kind of same thing with Elizabeth saying of like drinking alcohol and there's just no effect really. But then also on the food side, there has to be, I feel like, something with the dopamine reward pathway with the drug, because eating, yes, like it's different, but it has completely changed my relationship with food. And when I used to eat like chocolate cake with peanut butter icing, like that was my go-to for like that dopamine, like that's my thing. It's not there anymore. And I'm like, no matter what I eat, it's just like I don't feel that like attachment like I did. So I could see maybe there's something there that we just don't know yet.
Yeah, it's really
Yeah, and I think I think that's interesting because I mean, right, those are the targets. Is it dopamine or is it that, you know, like if you think about like the biology of like what happens in diabetes, which is where you're right, and a lot of the diabetes mood craving sort of thing comes from also dysregulation of that inhibitory excitatory mechanism and the dysregulation that causes the inflammatory flares and actually, I mean, this is a whole, I mean, you want to go nerdy, there's actually this whole philosophy, we don't have drugs that target about inflammatory conditions that trigger both mood and addiction behavior. And none of the current targets of any of these things target that pathway. And so you can record me saying this. I would not be shocked if, because of it's looking at its full use pattern and what people report from diabetes to the emotional stuff, I would actually not be surprised if the true mechanism of action isn't anti-inflammatory in a way that's driving dopamine and driving cravings. But I don't, because we do have evidence that it has some anti-inflammatory pathways, but I do not think that substance use disorders or even psych disorders in general for that matter have really truly gone into understanding that full anti-inflammatory pathway mechanism for mental health disorders or substance use disorders. But if I was a betting person, which I'm not, that would be my guess. But I don't know.
I love it. I love the nerdy talk. Thank you, and thank you. Those have to leave. That's yeah, this has been a great discussion, and I just always love listening to you guys. Anybody else? We're right at 2 minutes. I don't want to rush though, of course. All right. Well, I just have one announcement then. It looks like we're gonna meet on the